Assalamu alaikum everybody. My topic today is adenomyosis and infertility, an updated review. The content of my topic includes a short background, diagnosis of adenomyosis, mainly with ultrasound and MRI and hysteroscopy, adenomyosis and infertility, impact of adenomyosis on infertility, and lastly, treatment of adenomyosis. And as a hint, at the end of my topic, we will mention some articles about malignant potential of adenomyosis. We start with the background. Adenomyosis is defined as ectopic location of endometrial and stromal tissue distal to the endometrial myometrial junction with association of myometrial smooth muscle hypertrophy. Adenomyosis, approximately 20% of cases of adenomyosis are young than 40 years, and the vast majority are elder, about 40 to 50 years old. Adenomyosis can be asymptomatic or present with menorrhagia, with these symptoms usually occurring in patients ranging from 35 to 50 years old. The most accepted hypothesis for the etiology of adenomyosis depends on the invagination of endometrial physalis cells into the myometrium. That's to say, invagination of the endometrium physalis layer into the myometrium is the main accepted hypothesis of development of adenomyosis. Adenomyosis have diffuse haphazard distribution or more focal, known as focal adenomyosis. When women with the condition therefore present with enlarged POGI uteri. Diagnosis of adenomyosis mainly depends on two tools in the routine practice in the gynecology. The first is ultrasound criteria, and the second is MRI, which is more accurate than ultrasound. The ultrasound criteria of adenomyosis include uterine enlargement with focal or diffuse hypoechogenicity in the absence of leiomyoma, loss of normal endomyometrial interface, increased or decreased areas of echogenicity, cystic structures within the myometrium with increased color Doppler flow. These are the main four ultrasound criteria to diagnose adenomyosis. These are ultrasound pictures for cases of adenomyosis, including the diffuse generalized adenomyosis and the more focal one. This is another ultrasound picture for focal adenomyosis. The color Doppler distribution showing anechoic cystic lacunae in the posterior uterine wall, as the arrows points, with a heterogeneous echo texture. The MRI diagnosis of adenomyosis depends mainly on the junctional zone, which is a region representing the inner myometrium and is very important imaging feature in the pelvic MRI for interpretation of various pathologies. In its intact state, it is usually visualized as low T2 signal layer beneath the endometrium. This low signal intensity is thought to be from closely packed, compact, smooth muscles with little extracellular matrix and water content. So the junctional zone between the myometrium and endometrium is the mainstay in the MRI diagnosis of adenomyosis. Assessment of the thickness of the junctional zone is the mainstay. The consensus for diagnosis of adenomyosis is when the junctional zone is greater than 12 mm, but the disorder can be suspected when it is between 8 and 12 mm width. The criteria for diagnosis of adenomyosis by MRI include the following points: focal diffuse thickening of the junctional zone more than 12 mm, low signal intensity uterine mass with ill-defined borders, junctional zone thicker than 12 mm as we see before, poor defined junctional zone borders, localized high signal foci in an area of low signal intensity, linear striation of increased signals radiating out from the endometrium into the myometrium, bright foci in the endometrium of similar intensity as myometrium, T1 weight, ratio of junctional zone thickness to myometrium thickness ratio more than 40%. These are the main 8 criteria for MRI diagnosis of adenomyosis. These are pictures of adenomyosis on MRI. This is a focal adenomyosis. This is a more or less diffuse, mainly posterior wall adenomyosis, and this is also enlarged mainly on the posterior wall adenomyosis and anterior wall adenomyosis, and this is the bladder and anterior wall adenomyosis. Is MRI better or ultrasound for adenomyosis? The advantage of MRI over transvaginal ultrasound is that MRI has a greater specificity and can differentiate adenomyomata from leiomyometer. When non-invasive diagnosis with MRI and TVS imaging became available, the role of adenomyosis in infertility and early pregnancy was better recognized and researched and evaluated. We come to the third, more recent modality for diagnosis of adenomyosis, which published by Gort et al. 2018, which is the hysteroscopic diagnosis of adenomyosis. Gort tells us that adenomyotic hysteroscopic imaging becomes pathognomonic for subendometrial exploration. So, if we perform subendometrial exploration by a cold scissor with hysteroscope, we can be sure that the lesion is adenomyotic. These are lesions with the ostia and some cysts. We'll come to the detail later on. Visible endometrial defects on uterine septum is suggestive. After incision, different cystic structures become visible. Incision of lateral wall of the uterus reveals the presence of adenomyotic cyst, opening of adenomyotic cyst, formation of cysts, still small opening is present. Opening of this defect shows the inner side of the cyst. These are all pictures of adenomyosis with hysteroscopy. Progressive dissection of cysts with scissors. View of dissected cysts, arrow, as the arrow shows here, showing the opening of the initial axis with scissors, and lastly, postoperative control after 12 weeks. After 12 weeks, defects is still positive. These are all published in 2018 by Gort et al. Is adenomyosis a cause of infertility? There is a significant association between pelvic endometriosis and adenomyosis, with estimates indicating that it occurs in about 50% to 90% of cases. Because endometriosis is a well-known cause of infertility, there was a concern that findings of infertility were due to concurrent endometriosis rather than adenomyosis. A recent meta-analysis performed by Young et al. 2017 concluded that adenomyosis has a detrimental effect on clinical outcome of in vitro fertilization in women undergoing IVF, rates implantation, clinical pregnancy per cycle, clinical pregnancy per embryo transfer, ongoing pregnancy, and live birth among women with adenomyosis were significantly lower than those without adenomyosis. The miscarriage rate in women with adenomyosis was also higher than in those without adenomyosis. How adenomyosis cause infertility? The mechanism by which adenomyosis cause infertility may be due to affection of uterotubal transport or endometrial receptivity affection due to estrogen production by the tissues, or affection of implantation due to disturbance in the adhesive molecule, mainly the HOXA. Is there an association between adenomyosis and oocyte function? There is no association according to Sanchez et al. 2017. Treatment of adenomyosis based on limited available evidence. Patients with adenomyosis could be treated with medical and or surgical therapies to improve pregnancy and birth outcomes. Treatment with gonadotropin releasing hormone agonist serves to downregulate the pituitary, exerts an antiproliferative effect, promotes apoptosis, and reduce the anti-inflammatory and angiogenesis effect. Multiple case reports show conception and live birth in women with infertility and adenomyosis after pre-treatment of GnRH agonist for 3 to 5 months. In other retrospective studies, pre-treatment with GnRH agonist prior to fresh or frozen embryo transfer appears to be effective in increasing pregnancy rates. The uterine preserving surgeries have shown benefit for women with adenomyosis and experienced previous IVF treatment failures, especially patients less than 39 years. In retrospective studies, conservative surgery or combination of surgery and GnRH agonist has shown to be more effective in controlling symptoms and also in increasing pregnancy and live birth rates when compared to GnRH agonists alone in patients with extensive adenomyosis. These are techniques, surgical techniques for management of adenomyosis described by OOCYTE et al. 2011. These are classical adenomyomectomy, H incision, and triple flap method. And lastly, laparoscopic cytoreduction surgery. These are the diagram for the procedure that may be followed up in video source. HIFU, high intensity ultrasound energy, is tried for the management of adenomyosis. However, patients typically subjected to HIFU must be to 18 years or older, premenopausal, have no history of pelvic inflammatory disease or severe pelvic endometriosis, symptomatic adenomyosis with junctional zone thickness more than 3 cm, 30 millimeters for diffuse adenomyosis, or a lesion diameter between 3 to 10 cm for focal adenomyosis. These are typical patients for HIFU treatment of adenomyosis. Is HIFU treatment for adenomyosis beneficial? A recent retrospective study showed high rates of conception and live birth in HIFU treated patients with adenomyosis, suggesting that it is promising non-invasive fertility sparing treatment option. In another study, pregnancies after HIFU resulted in 2 miscarriages and the delivery of 4 healthy babies. One delivery was complicated by major placenta previa and hemorrhage. This is according to Zhu et al. To 2011. Is adenomyosis subjected to malignant potential? The malignant transformation of adenomyosis is thought to be due to its endometrial epithelium transition to monolayer tumor cells before malignant transformation, which eventually develop to a varying degree of cancer. However, the specific molecular mechanism of adenomyosis is not yet clear because of its low incidence of malignancy transformation, lack of large sample multicenter clinical trials, and large heterogeneity of the existing research. The evidence based on high factor of malignant transformation of adenomyosis. We completed our talk. Thank you very much for letting me sharing in your valuable conference. Thank you very much.